Yeah, so periprosthetic infections, as we all know, is a complication of arthroplasty that none of us really wants to have. And if possible, we should all try to avoid it, do all we can to avoid periprosthetic joint infections. It is a serious complication which leads to a big economic impact to our patients and a lot of stress for the surgeons and the patients as well. As you all know, most of our patients can just raise enough money just for the primary joint replacement. And now when you have infections, it is really a nightmare for the patient. So it's one of the complications that we all really have to avoid. And we are going to talk more about infections in the knee and the hip, but it also applies to shoulder prostheses because they also get the same kind of infection and almost the same pathology. It's the elbow replacements, however, have a higher rate of infection because most of the elbow replacements are done for rheumatoid arthritis, which is a high-risk disease. The prosthetic joint infections is on the increase because of the large number of arthroplasties which are increasing in our country. The incidence globally is 1 to 2% for primary total hip replacement and about 2 to 2.2% for primary total knee replacement. In revisions, of course, you have a higher infection rate, like 4%. But these are global figures. I think our local figures are higher than this. So we see more periprosthetic joint infections. The organisms causing are many, but I've listed here the common ones. The commonest one is Staphylococcus aureus, which is responsible for the early onset prosthetic joint infections. We have also Coagulase negative Staphylococcus aureus. This is a slow growing organism and is responsible for the late onset joint infections. And then you have the other Streptococcus, Enterococcus. Propionibacterium is a bacteria which is very difficult to culture and also is responsible for the chronic prosthetic joint infections. You can also have fungal infections, especially in drug users, or many other organisms can do that. Now, classification of PJI. There are many classifications, but the classification we are going to use is the one by Tsukayama, which was done in 1996. And this one is good because it has clinical implications and it's useful when you're setting up treatment. So it's divided into 4 groups. The first one is positive intraoperative cultures, which is incidental. I mean, maybe patient was going in for a septic revision, and you take a swab, and it comes back as positive. And most of these patients actually don't go and develop a PJI. And so these ones are usually given their own group. And then you have group 2, early onset. These are infections which are starting less than a month after your primary joint replacement. Usually these are intra-op infections and are usually caused by Staph aureus or other very virulent organisms. And then the third group are the late or chronic prosthetic joint infections. These are infections which are occurring after 1 month from your primary joint arthroplasty. These are usually by the slow-growing organisms, and still most of these are intra-op infections. And then the fourth group are the hematogenous infections. This usually occurs it can be several years after the primary joint infection. And usually it's just out of the blue. A patient who was normal suddenly comes with a swollen joint. And when you take proper history, you might find there was a focus of infection somewhere in the body, which led to bacteremia and hematogenous infection. This is from the article I was reading. This is an article from Effort. It's just the same things that we have talked, but he has sort of separated them. You have 2 groups, acute prosthetic joint infection and the chronic prosthetic joint infection. As we have said, the infection is usually less than 4 weeks The chronic one, infection is after 4 weeks or 1 month. The hematogenous one, if the infection is within 3 weeks from the onset, that one is early or acute. If it is more than 3 weeks, you treat it as a chronic infection. Clinical features for acute, just acute inflammatory process. So you'll see they'll have pain, fever, redness, swollen joint. And for the chronic one, they will come with a discharging sinus, chronic swelling, chronic pain. The causative organisms for the acute PJI is the Staphylococcus aureus, that is the commonest. You can also have gram-negative bacteria, E. coli, Enterobacter, Klebsiella, and Pseudomonas. Whereas the chronic one is usually due to coagulase-negative Staphylococcus, Staphylococcus epidermidis, and then other rare organisms. If you have acute PJI, in other words, if your patient develops infection within 1 month after your primary surgery, you can actually debride and change the mobile parts like the liner and the head, and you can retain the implants. Whereas if the patient comes, after 1 month after your primary surgery, then you have to change, either 1 stage or 2 stage exchange. The important thing here is the biofilm. The biofilm actually takes 4 weeks to form. So the infections that occur within the first 1 month after your surgery, the biofilm has not formed. That is why you can actually debride and retain the implant. But after 4 weeks, the biofilm has formed. And the biofilm is a glycocalyx matrix, which is secreted by this bacteria. And the bacteria, the antibiotics cannot actually reach the organisms in the biofilm. And those organisms, they are usually they're in slow, non-growing state. And occasionally some of them break off from there and lead to signs of inflammation and infection. So risk factors, these are some of the risk factors you have to have in mind when you're doing your arthroplasty. If you're doing a patient who has rheumatoid arthritis, then you have to take precaution because it's an immunosuppressive condition and most of them can develop infection. Or they are on disease-modifying anti-rheumatic drugs like Lefra or methotrexate. So if possible, you should stop them before your surgery and don't start them until your wound has healed. Then they can go back to their drugs. Lifestyle factors, of course, obesity with the BMI more than 35 is a risk factor because surgeries take long, wound problems. But there's nothing you can do. Long ago, patients used to be told to go and lose weight before they come for arthroplasty. But it doesn't work because most of them just go and sit at home and you find they still come back with the same weight. So we just have to take precaution and do the surgery. Smoking, of course, alcoholism, intravenous drug use, and poor oral hygiene and UTI or other infections somewhere in the body. So always take your time to make sure there are no foci of infection anywhere in your patient before you do arthroplasty. Diabetes is a very important factor which we should all be careful about. Apart from doing your random blood sugar when the patient comes, always do HbA1c so that you know what kind of control the patient is having. If possible, diabetes should be well controlled before you do your arthroplasty. One of the papers I was reading actually said if there is high sugar during the preoperative period, that patient tends to have a higher risk of infection. So it is quite a serious problem and it needs to be controlled. I think the others are self-explanatory. HIV, if the CD4 count is less than 400 and some articles say less than 200, I think you should be wary about doing a total joint replacement. If possible, you can let them build up and then come back for total joint replacement. Clinical features, I think this usually pain is the main thing. Most of them come with pain. And if your patient who was normal, who had actually improved after your surgery, starts developing pain, think of infection unless proved otherwise. Of course, there are other factors, but infection should be ruled out. Joint swelling and erythema, warmth around the joint, and of course, discharging sinus is a factor. Now, the investigations which are done for periprosthetic joint infections, the first one is blood works, and the WBC usually is not very helpful. Of course, unless of course you have a very acute infection, but most of the time it's not raised. ESR and CRP are the most important, and they should always be done. If both of them are normal, then chances of you having infection are very low. D-dimer also is useful. This is because sepsis tends to interfere with the coagulation system, and the D-dimer actually goes up, so it's also an important thing that can be checked. Interleukin-6 can also be checked, and you can see it is a highly sensitive marker. So if it is high for those centers that can do it, then it means that you're likely to have infection. And then imaging, of course, X-ray, plain X-ray, then you will see the usual features of loosening or osteolysis. And once you see that, then it's just think of infection until proved otherwise. CT scan is important, especially if you are thinking of if it's a hip problem, because just to ascertain the bone defects. MRI can give you more information about soft tissue abnormalities. We rarely do it. Most of the time, it's just X-ray and CT scan, especially for the hip. You can see this is a patient who had a revision after 1 year prior to this. And you can see within 1 year, the patient has already developed loosening. You can see osteolysis along the femur. And when you see this kind of situation, then you know that most likely is a septic problem, and needs either 1-stage or 2-stage revision. Other imaging modalities for those centers who can do, you can do technetium 99 bone scans, highly sensitive but not very specific. You can increase the specificity by using indium 111 labeled white blood cells scan, which will be slightly more specific than the technetium 99. SPECT can also help. PET scans also are important it can also help in this. This is because sometimes you are completely unable to decide whether is it a septic or not septic loosening. So sometimes some of these tests come handy here. Now, once you think you have seen the parameters are positive, then ideally you should do joint aspiration. I know most of us have been wearing doing joint aspiration, but it's one of the things that can be done just to investigate your to see whether you actually have PJI before you embark on your surgery. And they should be done in theater, and if possible, you should make a small stab before you put your syringe and needle, so that you avoid skin contaminants. And you take you aspirate 2 specimens from 2 sites using different needles and syringes. And if the 2 of them are positive, then you know that it's a joint infection. The synovial fluid, then you look at the color. If it's purulent, of course, then you know this is pure infection. The leukocyte count, if it's more than 2,000 per microliter, granulocytes of more than 70%. And then it is done culture, yes. And culture should not be just for 3 days that we normally do. They should, of course, report at 3 days, but they should have culture for a longer time. This is because some of these slow-growing bacteria will take time before they are picked. Sonication fluid. How you get this is once the implant is removed, in those centers where they do that, they subject you to a small ultrasound waves, and that disintegrates the biofilm, and the fluid is washed and is taken for culture. And that one gives you diagnosis also for your PJI. PCR, so the synovial fluid can be taken for polymerase chain reaction. And this is a very useful thing for those centers that do it, and you can get your diagnosis of what kind of bacteria you have. And the leukocyte esterase, I think I have a slide on it in front. This is a dipstick. You just take a drop of synovial fluid and use that, and it will tell you whether you have infection. I've had many times myself where I've opened the hip or the knee, and I can't decide whether is it infected or not infected. The synovial fluid looks neither here nor there. Those are the ones that can do well with this kind of tests. Alpha defensin also can be done. That is a leukocyte esterase strip. You can see how it looks like. Leukocyte esterase is actually an enzyme secreted by activated neutrophils, which migrate to the joint during inflammation, and you can see that it is highly specific. If it is positive, 2 pluses, then you're likely to have infection. And it's just a drop of synovial fluid that you use to do that. The fluid should be clear. The synovial fluid should be clear. If it has blood stains, then it can give you a false positive test. So some of the labs actually take the synovial fluid and centrifuge it so that you remove all the blood cells, and then you can do the dipstick. Mm-hmm. That is alpha defensin for those centers that do that. Also, it's highly specific. It's still the same as leukocyte esterase. And then, of course, during surgery, samples are taken, and the recommended is 5 samples are taken. 5, and if 3 of the 5 are positive, then you know that it is infection. You can also get false positive, of course, and one of the samples is taken for PCR. Yeah, then you send it for histology, and they'll be able to tell you whether you have infection. There is a criteria which has been set by the Musculoskeletal Infectious Society for the diagnosis of prosthetic joint infection, and it has a major criteria and a minor criteria. The major criteria are 2, and if any of this is there, then it's confirmed to be joint infection. If you have a sinus tract which is communicating with the prosthesis, that means if it is there, then you're dealing with VJI. If you have 2 or more cultures which have identical microorganism, then also that is confirmatory. And then the minor criteria are here; they are listed here. And if you have 6 points, if you add this, then you have a PJI. So those are the like CRP, D-dimer, ESR, synovial white blood cell count, alpha defensin, leukocyte esterase. Yeah, all those CRP, then you know that you have. They also have intraoperative criteria, which I think we have talked about. Maybe I'll come back to that. Treatment options for prosthetic joint infection that we have accessible to us. One is debridement and retention of the implants. This is when your infection is less than a month. You can debride, give antibiotics, and you still retain your implants. You just change only the mobile parts. You can have 1-stage revision. You can have 2-stage revisions, short interval. That is, you change your you reimplant after 2 weeks. 2-stage revision, lock interval. This is a common one. This is our gold standard, where you do implantation after 6 weeks. You can have 3-stage revision. This is where you keep changing the spacers before you finally come and do your implantation. Or you can do a girdle stone or chronic antibiotic suppression or amputation. We're going to look at I have some slides on this, and maybe we can maybe go back. Yes, I don't know that you can see this slide. It's summarizing. It's summarizing all the treatment options that I've talked about. And if you look at this is a DAIR, debridement, antibiotics, and implant retention is this one. So what happens is the infection is less than a month. So you debride, change the mobile parts, that's the cup and the head. And then after that, you give the patient antibiotics for IV antibiotics for 2 weeks and oral antibiotics for 10 weeks. So you're giving antibiotics for 12 weeks. Okay, and then also if you do one stage exchange, which you do it here, you give your IV antibiotics for 2 weeks and then continue the oral antibiotics for 10 weeks. That is, so you give again 12 weeks of antibiotics. And then if you are doing two-stage exchange, you can do the short interval. The short interval is where you do your debridement, put a spacer, and then reimplant after 2 weeks, and continue again your antibiotics for 10 weeks. This is our gold standard one that we normally do. Debride, remove the implants, put a spacer, reimplant after 6 weeks, and continue antibiotics for 6 weeks. Here, this one here is a 3-stage exchange. This is where you change your your spacers in between until you finally do your implantation. But I'm going to explain in the next. So this is the first stage. If your infection is less than a month, so you do this one. Is called DAIR, which I've just explained before. Debridement, antibiotics, and implant retention. The most important thing here is radical debridement. I think you have to do adequate debridement, excise everything, the synovium and all that, and then excise the sinus tracts, copper irrigation with a lot of saline, of course, and if possible, use a pulse lavage. This one will give you a better debridement or a washout, and then you exchange mobile parts, that is the head and the cup. And some people use methylene blue during this, when they're doing this debridement. I've never used it myself, but of course I've read in the books. So you stain once you have opened your joint, you stain it with methylene blue, then wipe it dry, and excise all things that have been stained by methylene blue. And I've seen literature, it is quite a good way of making adequate debridement. And if you want to use antibiotic beads, use absorbable antibiotic beads, which you don't have to come back to remove. But it's not necessary to use, but of course, if you want, you can do that. So this one you do if your infection is less than a month. But if your infection is more than a month, then you have to decide whether you want to do 1 stage or 2 stage. 1 stage, of course, is attractive because it is cheaper, short hospital stay, less morbidity, quicker rehabilitation for the patient and return to function. But the key thing to do 1 stage revision is strict patient selection. You have to know which patient to do 1st stage and which one to go for 2nd stage. And you must have microbiology support. You should know actually the organism, so that you can actually use the correct antibiotics. So, like in Europe, there are some centers which specialize in doing 1 stage revision. I was lucky to go before the COVID to go to Endo Clinic, which actually does 1st stage revision, and it was quite exciting to see how they do it, how the amount of debridement they do, and how they put they do their 1st stage. But for you to do 1st stage, the bone and the soft tissues must be in good condition. If the bones and the soft tissues are in terrible condition, then it's better you go for 2 stage. But if they are good, you have debrided and it looks good, then you can think of that. The microorganism should be known, and sensitivity also should be known, so that you use the correct antibiotics. And most of the people who do revisions use use the cemented implants, so that they put the correct antibiotic in the cement. But you can also do uncemented. But most of the ones, they still use that. And as we say, then after that, you'll give antibiotics for 12 weeks. Now, the 2 stage, there are 2. There is a short interval where you change after you reimplant after 2 weeks, or implant after the long stage the long interval where you implant after 6 weeks. Before I did this presentation, all my were 2-stage. I used to implant after 6 weeks. But when I read these and read the articles that have gone through this, it looks like it's a good option, because sometimes after your debridement, it looks, the joint looks so nice. You feel like actually implanting. But then you think of waiting for 6 weeks. But I think if you debride and it looks good, you can actually close it, come back after 2 weeks and do your 2-stage implantation. And after this short interval, you should give you antibiotics for 12 weeks again. Yeah. Yeah. Now, 2-stage revision. 2-stage revision, long interval. This is actually the gold standard that we have all been taught. And it's highly recommended if your bone and soft tissues are not in good condition. If you are dealing with difficult to treat organisms like Staphylococcus aureus or other difficult organisms, then 2-stage long interval is the best solution. And then after that, you'll continue antibiotics for 6 weeks. Yeah. This one, 3 stages where after you have done your you have done your initial debridement, removed all the implants and put your Spencer, you still find a lot of drainage. So what you do is after 2 weeks, go back, open it, wash it, remove the spacer and put a new spacer, and then again see at 6 weeks how it is like that. Until you're satisfied, then you can go ahead and do your implantation. For most of us, we normally debride and then put a spacer and call the patient back after 6 weeks. When you go in, you find infection. So when you find infection, then what you do, you exchange the spacer, put a new one, and then again call the patient back after 6 weeks. So these are the 3-stage or multi-stage kind of revision. And it's also one way of dealing with it. I wanted to say something about antibiotic cement spacers. We have 2 types. We have the synthetic ones, like the ones you can see there on the photo. These ones are synthetic. They come pre-made, and most of them have either tobramycin or gentamicin. They only limit you to those 2 antibiotics, and most of the time you don't even know what concentration of antibiotics they have. And they're also brittle. I think we used one of these one time, and patient came back, it's broken. So they are not really the best. Most of the time, as we make our own spacers, but if somebody wants synthetic prefabricated spacers, then they're also available. And so these are articulating, but you can also have static, like putting a bone block or bone beads, then putting a cement block or antibiotic beads. Those are static spacers. The commonly used organisms, of course, are vancomycin, gentamicin, and tobramycin. And you should not use too much cement, too much antibiotics in the cement. It should not be more than 8 grams of antibiotics in 40 grams of cement. This is one of the patients that we had in St. Luke's, and she came with quite a very bad infection, and we removed the implants. We removed the implants and made our own spacer. This spacer is we actually make it ourselves in theater. And the way you make it is you take a small balloon like the one they use for, I don't know if you've seen the one the ENT people like using to clean the ears, that round balloon. So you cut it and then fill it up with cement, and then take a rod, like this one was an old kernel which was sitting in theater. We just bend it and then put it inside into that balloon and fill it up with cement. And then you cut off the balloon and you have a very round, nice cemented head, which you can use, which is actually a spacer. And the antibiotics you put here will depend a lot on what kind of organism you're dealing with. But for us, because our microbiology is no good, most of the time it's just vancomycin, tobramycin, and gentamicin most of the time. And then, of course, after 6 weeks, you can now reimplant, do your final implantation. This is another patient who had infection, so we also did. So this one you can see we're using beads. This is because we have gone through all of them. We have gone synthetic. We see the infection doesn't go, they break and things like that. Then I used antibiotic block, static block. Still, our antibiotics are not, doesn't elute antibiotics very well. Our cement doesn't elute antibiotics very well. So I ended up coming back to using beads, and most of the time it gets rid of the infection. Most of these patients, after that, you can, for the knees, after second stage, you usually use a hinge knee for that. Yes. Now, sometimes if the infection is very stubborn, you can decide to permanently remove the implants and not reimplant. If you are dealing with patient is in poor general condition or economic reasons, or the infection is stubborn, then you can just remove the implants and leave the hip as a girdle stone. Or in the knee, you can leave without implanting, or you can do arthrodesis. Arthrodesis also is a good way of solving knee problems after infected implants. But even dissecting and leaving without implantation, if it's, especially if it's an elderly patient, they can actually stay without any implant in the knee because eventually the pain goes, and when they sit, the knee can actually bend, and they're happy about that. But if it's a young person who still wants to move around and all that, then it might be better to do arthrodesis. Okay, and then after that you continue antibiotics. So this is a patient who came also to us in St. Luke's with very bad infection. I think even from where he came from, everything had been done, but the infection was really virulent. And so we removed this. There were even some beads inside which had already been put. We removed them, and then put new antibiotics, cement beads with the vancomycin and tobramycin. But the infection continued. It kept on oozing and oozing. And so eventually we decided to remove everything. Sorry about that. We decided to remove everything. So here we had removed all antibiotic beads and put a drain, and we left it. So right now he has healed. There is no more discharge, and he's happy. There is no pain. He's hobbling around with crutches. He's happy with that. But the sad thing is, the other day he came and told me he wants to have a new joint. So then I was feeling that, we don't want to go back where we have come from. I think it's better off just using crutches, and no infection. The wounds have all healed. This X-ray was the one immediately after removal of beads, but right now he's in a very good condition. So sometimes it might be better to leave a patient without any that. Some patients, elderly patients who have very bad infections and rotted joints, sometimes it might be better just to give them antibiotics and leave them alone. Chronic oral antibiotic suppression therapy. I have a patient who has eroded acetabulum, the femur, and is having a discharging sinus, but he's elderly. So I've decided just to give him antibiotics. He has a discharge, of course, which he keeps on dressing on and off, but it's better than trying to operate him. So sometimes it's an option for patients who are inoperable or they are too old, and that's something that can be done. Amputation, this one we have done a few of them. That is when all the other methods have failed. The infection is life-threatening, or the limb has become dangerous or nuisance, then you can do that. It happens. We have done a few also in our hospital with that kind of problem. So thank you very much. That is the end of my presentation. Thank you so much for listening, and thank you.
Thank you, Prof. Lelei. Allow us to call you that. We feel your contribution to the practice warrants you to be called Prof. So Irene is going to launch the poll. Prof. Lelei, you work out to you for the questions.
Yes.
Irene, you launch the poll. So the poll for a minute. Prof. Lelei, you're able to access the questions?
Yes, I can see them. Yes, thank you.
Oh, okay, you can be responding to those as the poll goes on.
Okay, let me. Sorry, I think I lost them.
They are on chat.
Oh, yes, I can see. Yeah. The question from Omamo: what precautions do you take on patients who have had chemotherapy and need arthroplasty? I think there is nothing really specific for patients who have had chemotherapy. I think what is important is there should be a period between chemotherapy and your arthroplasty. And so before surgery, of course, you do your normal parameters, your HB, to make sure there is no infection or any other issue. And then you can do your arthroplasty. After that, if anything has to be started, at least your wounds should heal before radiation or chemotherapy is started. So like I would say, probably give it like a month after your surgery before they go back to their chemotherapy, and maybe a month before your arthroplasty, and also make sure, of course, all the parameters are normal. Yes, thank you. What do you do if CD4 count doesn't improve? Maybe the nutritional status and current infection may be more important. Current studies have started moving away from specific CD4 levels. Kindly clarify. That is from Singh. I think that should be Chawan. Yes, I think that is a very important question, because most of these patients, like I've seen some where they are HIV positive, they look really, wasted and that, but they say, no, me, I want my joint to be done. What do you do about that? Okay, there are some who have actually told them, given them time to improve their nutrition, and if there are any concurrent infections, they get treated, and if they improve, then we go ahead and do arthroplasty. But I think it can be dangerous if the patient is in poor general condition, both nutritionally and the immune status. So try to improve that before you do your arthroplasty. You forgot to say that serum lactate is an important measure of infection in acute setting. Yes, thank you very much. That is Dr. Muduri. Thank you so much for that. Yes, I think serum lactate also for those centers who do that should also be done. That is also quite important. There are quite a number of things which I've seen nowadays people doing. I think the other one was of course, we have talked about D-dimer. There is serum lactate. There is I can't remember of it now, but there are quite a number of tests now being done to pick that. But thank you for that input, Dr. Muduri, about serum lactate. Okay, about the revision between cemented and uncemented stems for revision or implants for revision. Most centers up to now, they used to do cemented revisions. The reason is because they wanted to put the correct antibiotics in the cement. So, for example, if the staphylococcus is sensitive to clindamycin, so what they will do is they will do cemented and add clindamycin in the cement. But as you correctly put it, I think this is Dr. Barak. As you correctly put it, there is literature for everything. There are some who say it's better to do uncemented, and I think it is okay. It depends also on your bone quality and things like that. So you can make a decision. But the reason why they liked cemented is because they wanted to use the correct antibiotics in the cement. Thank you. Yes, that is that. Thank you. Thank you, Dr. Great. Okay, so I don't know if there's any other question. Any other question from colleagues? Yes. Recommendation of post-op serial monitoring, CRP. Yeah. Yes, I think that is also important. So before you do your second stage revision, recheck your ESR and CRP and interleukin 6 levels, and you will see it coming down. If you find they're not coming down, or they're rising, or things like that, then you might have to actually to delay your second stage surgery, or go back with a double mind of going to rechange the spacer and give the patient another 6 weeks. But if you find it's coming down, the CRP and DSR is coming down, then you know that you are safe to do your second stage revision. Yes. So I think, thank you very much. I think there are no more questions. Thank you so much, and I appreciate for coming to listen. Yes. Okay, I think there is somebody who was asking about our old method. That is Dr. Lushola. He still remembers our old method of irrigating the joints with rifocin, which used to be done a lot those days. But it's no longer recommended now. I think the antibiotics that you're going to put in your cement or in your spacer, it should be adequate. But it's a method which you sometimes can use. We used it occasionally long ago with Professor Mulimba and the team, but nowadays it's no longer recommended so much. Yes, well, thank you very much. What is your opinion on using rifampicin? Yes, I think that is important. I forgot to say that. That is from Amai. Rifampicin and ciprofloxacin, they are actually called biofilm active antibiotics. So whenever you suspecting infection, or after your implantation of your second stage or first stage implants, always add rifampicin or ciprofloxacin to your antibiotic regime. I forgot to say that, but this is very important, and this is our practice. So if you have implanted your implants for infection, always add rifampicin or ciprofloxacin on top of your antibiotics. And rifampicin has been shown to be very good for biofilm by Staphylococcus aureus, and ciprofloxacin is good for biofilms from gram-negative bacilli and other bacteria. So, but most of the time, because we know the commonest organism is Staphylococcus aureus, we add rifampicin. Most of the time, we give like 600 milligrams BD on top of your other antibiotics, and it tends to work very well. Yeah, thank you very much for reminding us that, Dr. Amai. Yeah. Mm-hmm. Yes. Mm-hmm. Methylene blue or betadine can help you define boundaries for debridement. That is Lutomia. Thank you so much, Lutomia, for that. I have not used it personally, but I know people use it. Methylene blue is, as I said, is diluted to 0.1%, and then you pour it into the wound. After that, you dry it up and remove everything which got stained, and that helps to pick up. And as Dr. Lutomia correctly said, even betadine can do that. As I said, I've not used it myself, but I know colleagues use it, and I think Lutomia also uses, so it's a good stuff. Thank you. Mm-hmm. Yeah. Is there any more question? I think we are done. Yes. I really appreciate Irene and Dr. Irimo and KOF for this opportunity. I think it's a good thing. I think this Zoom is bringing all of us together. Maybe something we should continue even after COVID. Thank you.